So first of all, we have started with musculoskeletal skin and connective tissue anatomy and physiology. So at first we have rotator cuff muscles, in which shoulder muscles that form the rotator cuff are supraspinatus, infraspinatus, teres minor, and subscapularis. Supraspinatus is suprascapular nerve, abducts arm initially, then before the action of deltoid. Most common rotator cuff injury, trauma or degeneration and impingement. There is tendinopathy or tear assessed by MT full scan test. Like either a person can fully abduct the arm or not. If he can abduct arm fully, it means his deltoid and everything is working. If not, then it means it is injured, most probably the supraspinatus. Infraspinatus is a suprascapular nerve, externally rotates the arm externally, pitching injury. We call it pitching injury. Then we have teres minor, which is innervated by axillary nerve. It adducts and externally rotates arm. What does it do? First of all, teres minor, axillary nerve, it adducts and externally rotates arm. Then we have the subscapularis, which is upper and lower subscapular nerves, internally rotates and adducts arm. And it is innervated primarily by C5 to C6. So you are getting my point. What is it? It's supraspinatus, subscapular nerve, infraspinatus, subscapular nerve, teres minor, axillary nerve. Okay. See, it is near axillary nerve place. Then we have subscapularis, which has the upper and lower subscapular nerves. And it obviously it will rotate it internally and it will adduct the arm, where supraspinatus will abduct the arm. It will move the arm outside of the body, like not outside, away from the body. Most common rotator cuff injury, trauma or degeneration and impingement happens. Then you have tendinopathy or tear. Infraspinatus. In infraspinatus, you have the externally rotates arm and pitching injury. Arm abduction. Now come on to the arm abduction, how it happens. We have read the first line already. 0 degree to 15 degree, the muscle involved is supraspinatus, and nerve is suprascapular. And 15 to 100 degree, we know it is deltoid. It is deltoid, and the nerve involved in deltoid is axillary, because it's very near to axillary. Then in more than 90 degree, the muscle is trapezius, and the nerve involved is accessory. And more than 100 degree, we have the serratus anterior. And more than 100 degree, we have the serratus anterior, in which we have the long thoracic. So they say it's a salt. First, it's not salt, it's a salt. So first of all, you have the suprascapular, then you have the axillary, then you have the accessory, then you have the long thoracic. 0 to 15, you have supraspinatus. 15 to 100, you have the deltoid. And more than 90 degree trapezius acts as an accessory. It will help, and nerve will be accessory. More than 100, it is the back, it's the serratus anterior. Very good. Now comes the upper extremity nerves. It's very important to know. Number one, upper extremity nerves, in which we have axillary, it is C5 to C6. What happens if there is a fractured surgical neck of humerus? What is it? Fractured surgical neck of humerus, and it will cause anterior dislocation of forearm, of humerus, sorry. So axillary, we know that it supplies the deltoid. It will not work. Loss of arm abduction at the shoulder more than 15 degree, and sensory loss over deltoid and lateral arm. This is what the axillary is all about. Then we have musculocutaneous, in which what do we have in C5 to C7? It is the upper trunk compression, upper trunk of the brachial plexus, So what happens in it? There is a decrease in biceps, which is C5 to C6 reflex. There is weakness of forearm flexion and supination. Supination is like your arm, your palm is up, loss of sensation over the lateral forearm. So in musculocutaneous, we have the biceps, which decrease in biceps C5 to C6 reflex, weakness of forearm flexion and supination. Obviously, the things which are done by biceps will not work properly, and there will be loss of sensation over lateral forearm, like here. And on lateral forearm, there is loss of sensation. There is weakness of forearm flexion and supination. So it is all about the forearm basically. So moving on, we have the radial nerve. What happens in the radial nerve? There is the compression of axilla. For example, due to crutches, crutches, the people who can't walk, they use the crutches for that purpose. Sleeping with arm over chair, like Saturday night palsy, and mid-shaft fracture of humerus. It's very, very common. We used to study it in second year of med school. So it's very, very common. And repetitive pronation, supination of forearm, for example, due to screwdriver use, for example, finger drop. So if there is like, if you are playing that game, Lok ki chupa ke dumerata ije, jera ke piche bekhyo disha mat aije. So if you are playing such a kind of thing, it will cause a repetitive pronation and supination of forearm. For example, due to the screwdriver use, and it will cause a finger drop, wrist drop basically. So in radial, we will have the wrist drop, which is loss of elbow, wrist, and finger extension. So it will be hanging. There will be decrease in grip strength, for example, wrist extension necessary for maximal action of flexors, and loss of sensation over posterior arm, forearm, and dorsal hand. Now we have median nerve. Median nerve has a very unique way of getting damaged. That is, it will be damaged by supracondylar fracture of humerus, which you have to remember. So this is humerus. When it is, when it meets the forearm bones, here it has a condyle. Here it has a condyles, and above the condyles there are the supracondylar fracture of humerus. So it will cause the proximal lesion of the nerve, and so there is a supracondylar fracture of humerus. There is a proximal lesion of the nerve, and then there is a carpal tunnel syndrome and wrist laceration, which causes distal lesion of the nerve. So number one thing is carpal tunnel syndrome. It will be compressed in carpal tunnel, and there will be wrist laceration. And there is third thing is there is distal lesion of the nerve. Ape hand and Pope's blessing. So you can get this injury, Pope's blessings and ape hand all are like this, two fingers working like this. So there is a loss of wrist flexion. Now flexors will go on. In the radial nerve, we have seen it, extensions and extensors are not working. In the median, we have seen it. The other thing won't work, like flexion. So we have flexions of lateral fingers, thumb opposition, lumbricals of index and middle fingers. Then we have loss of sensation over thenar, eminence, and dorsal and palmar aspects of lateral 3/4 with proximal lesion. So one thing that is important to learn is the loss of sensation. Where is it? In musculoskeletal, it is over the lateral forearm. In radial, it is over posterior arm and forearm and dorsal hand as well. Like starting from, but it has involved a complete posterior arm. Okay, forearm and dorsal hand. Then in median nerve, loss of sensation happens on thenar eminence near your thumb. Dorsal and palmar aspects of lateral 3/4 of fingers with proximal lesions. Okay, now we will move on. So now we have the ulnar branch here. Let's pause it. Okay, now we have the ulnar C8T1. Got it? So in which we have fracture of medial epicondyle of humerus, in which we have funny bone, where proximal lesion is caused and it leads to funny bone. Then we have the fractured hook of hamate, which is distal lesion from the fall of outstretched hand. It is often asked that there is a person who has a fall on his outstretched hand, where is the lesion? So if in this scenario, as you can see, if there is a fracture of hook of hamate, distal lesion from the fall on the outstretched hand, there will be a lesion of ulnar nerve. So ulnar claw or digit extension, because ulnar nerve is supplying only the is it medial or is it lateral? Lateral, this thing. Radial deviation of wrist upon flexion. Wrist flexion, flexion of medial fingers. Sorry, it is not the case. It is not this, it is this. This is a medial ulna supplied by medial. Okay. So loss of wrist flexion, flexion of medial fingers. Then we have abduction, adduction of fingers, introitiae, and then we have actions of medial two lumbrical muscles, loss of sensation over medial one by like their fingers, including hypothenar eminence. So as you can see there in this median nerve, there was a loss of sensation over thenar, and in thenar, like the thumb side, lateral side, in ulnar, there is a loss of sensation, but it is over medial 1.5 finger closing hypothenar eminence. So ulnar is C8 to T1, fracture of medial epicondyle of humerus, funny bone, fractured hook of hamate from the fallen outstretched hand, ulnar claw digital examination, radial deviation of wrist upon flexion, proximal lesion, loss of the wrist flexion, flexion of medial fingers, abduction and adduction of fingers, atrocia, action of medial two lumbrical muscles, loss of sensation over medial 1.5 fingers, including the hypothenar eminence. Then we have the recurrent branch of median nerve, in which we have the superficial laceration of palm. Okay. Superficial laceration of palm. Okay. A hand and loss of thenar muscles group, opposition, abduction, flexion of thumb, no loss of sensation. Okay, now moving on, we have discussed about recurrent branch of median nerve, which is C5 to T1. Superficial lacerations of palm can damage this, because median nerve goes like this, and recurrent branch of median nerve goes superficially in the hand. So then we have the ape hand, loss of thenar muscle group, opposition, abduction, and flexion of the thumb, no loss of sensation. Then we have humerus structure proximal to distal, follow the axillary, radial, and median. Shaft, like in supracondylar, it is median. In the radial groove, in the mid shaft, it is radial. Then axillary is in surgical. Here you can see that axillary is formed by C5 to C6. And C8 to T1 forms the radial nerve. Okay, and then we have radial nerve in spiral groove. And then we have the median nerve, radial nerve, ulnar nerve, axillary nerve, radial nerve, musculocutaneous nerve, radial nerve. Intercostobrachial nerve is here near the axilla. Then you have the medial brachial cutaneous nerve and medial anti-brachial cutaneous nerve. Sorry. Then in hand you have median nerve medially and radial nerve a little bit. No, median nerve is not medially. Sorry. Median nerve is lateral. Ulnar nerve is medial. And radial nerve is also lateral. Dorsum of hand, the major portion of chunk of the dorsum of hand is covered by radial nerve, a little bit by ulnar nerve, and a very, very, very little one by the median nerve. Okay. Now moving on. Now we have the brachial plexi, and the things which we will study in this brachial plexus lesions in are discussed here as well. First of all, we have the brachial plexus lesions. Number one is herb palsy, which is bitter tip. It is upper. Then we have the clamp case palsy, which is flow hand, which is nowhere, which is here. Then 3 we have wrist drop. In 4 we have the winged scapula, which involves long thoracic. And at 5 we have deltoid paralysis. In 6 we have the Saturday night palsy. That is a wrist drop. In 7 we have difficulty flexing elbow, variable sensory loss. Bob's flexing is decreased thumb function, medial flexors. And number 9, we have the intrinsic muscles of hand and claw hands. It's called Randy Travis strings cold here. So condition number, okay, so what they're telling us is that the C5, C6 combine together to form musculocutaneous. And this is upper arm of the brachial plexus. Then C5, C6, and C7 combine to form the kind of posterior C5, C6, and it will form the axillary and radial C6 and C5 to C7, I think. Then in C8, C8 and T1 both combine to form ulnar. It's very simple. Ulnar is formed very simply by the combination of C8 to T1 and C5 to C6 from the musculocutaneous. The problem comes when we are discussing axillary and radial and median is formed by the medial root of the ulnar and the lateral of the musculocutaneous, and then it is formed median nerve. And the axillary and radial is formed when we have this thing which is axillary, this is radial, this is posterior, and it forms everything and we have the long thoracic. So number one condition, we have Erb's palsy, which is later stiff, traction or tear of upper trunk, C5 to C6 roots. Okay, see, C5 to C6, here it will be Erb's palsy. Infants, in infants, what happened? There is lateral traction on neck during delivery. In adults, there is a trauma. And muscle defects. In muscle defects, we have deltoid, we have supraspinatus, and we also have infraspinatus. We have biceps brachii. You can see Erb's palsy. It is a kind of later step because it is like person is not can't bring the hand towards his front. It is on his back as if it is asking for some kind of a tip. So Erb's palsy, nerve palsy, we have deltoid, we have supraspinatus. Then we have infraspinatus and biceps brachii. If there is a deltoid and supraspinatus, there is abduction. Like functional deficit is the person can't abduct arm. Then if there is a lateral rotation, arm medially rotated. And then we have flexion, supination. Flexion is that hand is towards the sky. And supination, arm extended pronated. These are the deficits which a person cannot perform if there is an Erb's palsy, because there is a loss of a lot of stuff, like the musculo. Something will be gone of median nerve, something will be of musculocutaneous, so it's not a very good thing to happen. So we will need to repeat it again later. Now we have Klumpke's palsy. What happens is there's a traction or tear of lower trunk, T8 to T1. Infants, what happens is upward force on arm during delivery. Adults trauma, for example, gravity branch to fall to break a fall. Okay, so it can happen. There is that T8 to T1 loses its function. What defect happens in intrinsic hand muscles, lumbricals, introsci, thenar, hypothenar. So there is a total flow hand like a monkey. Lumbricals normally flex MCP joints and extend distal interphalangeal and proximal interphalangeal joints. Got it? Next thing that we have here is a thoracic outlet syndrome, in which what happens is a compression of lower trunk and subclavian vessels, most commonly within the Skelny triangle. So number thoracic outlet syndrome, what happens is a compression of lower trunk and subclavian vessels, most commonly within the Skelny triangle. Then there is cervical rib, Pankos tumor can suffer. Same as lumbricals like introsci, lumbricals and everything. Atrophy of intrinsic hand muscles, ischemia, pain, edema due to vascular compression. So what happens is a thoracic outlet syndrome, compression of lower trunk and subclavian vessels, most commonly within the Skelny triangle. Here is the Skelny triangle. Winged scapula, it's very common to ask and to be asked in paper questions. So lesions of the lower thoracic nerve, root C5 to C7, through the wings of heaven. Wow, wow. It's like wings of heaven. C5 to C7, wings of heaven. Nice, 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 nice. Axillary node dissection after mastectomy, stab wound, serratus anterior, embryonic scapula to thoracic cage, cannot abduct arm above horizontal position. So let's move to next.